Good afternoon, everyone, and welcome to today's webinar, The Importance of COVID-19 Data Empowering Communities Through Information. We're coming to you live from around the region this afternoon as a part of our ongoing webinar series hosted by the Atlanta Regional Commission. You can visit our website to find past webinars and to register for upcoming sessions. I'll post a link to ARC's webinar library page in the chat box. So let's cover a few housekeeping items before we jump into today's session. We've taken a screenshot of the attendee control panel. You should see something that looks like this on your own computer desktop in the upper right-hand corner, most likely. All attendees have joined in listen-only mode, so you will be on mute during today's webinar. However, throughout the webinar, you will have the opportunity to submit questions or comments by typing your questions into the questions pane of the control panel. You should see a little gray bar that says questions. You can send your questions in at any time during the presentation, and we'll collect these and address them during our Q&A session towards the end of the webinar. You will also see chat messages from us in that chat window where it says chat. So here's just a brief overview of the agenda today. We're going to do some welcomes, do our panels presentations, and then move into our questions and discussion before closing out. Today's meeting and all of ARC webinar series webinars are recorded through the GoToWebinar platform and will be made available to all meeting attendees via a follow-up email, and they will also be posted to ARC's website. Now I would like to turn it over to David Giguere. David holds a bachelor's degree in geography from Georgia State and is a certified GIS professional with 20 years of cartographic and GIS experience. An aspiring futurist and champion of entrepreneurial innovation, he seeks opportunities to design possible futures for our region. And throughout the COVID-19 pandemic, he has worked on a number of projects within ARC that focus on collecting and analyzing COVID-19 data. And today he will be our moderator for our discussion.
Thank you, Olivia. It is my great honor to participate with our panelists in this conversation about the importance of COVID-19 data and how we may empower communities through information. I would now like to introduce our audience to today's three panelists. Our first panelist is Dr. Cleo Andrus. Cleo is an assistant professor in the School of City and Regional Planning and the School of Interactive Computing at Georgia Tech. Her research is on mathematical models of social networks, social flows, and interpersonal relationships in geographic space, applied to issues of urban planning, visualization, transportation, and geography. She directs the Friendly Cities Lab, is a member of the Center for Spatial Planning, Analytics, and Visualization, and an affiliate of the Center for Quality Growth and Regional Development. She is also a member of the School of Interactive Computing's Information Visualization Research Group. Cleo's work on the COVID-19 Event Risk Assessment Planning Tool has provided COVID-19 event risk estimates at the county level or equivalent for citizens in the United States and abroad. Our second panelist today provides a state-level public health view of COVID-19. Dr. Amber Schmidtke is a public health microbiologist and science communicator. At the start of the COVID-19 pandemic, Amber recognized there was a large gap between the way that scientists communicate and how non-scientists receive information. She has combined her roles as a public health microbiologist and college educator to provide meaningful analysis and explanation of disease trends to the public through a very popular newsletter and podcast. Amber has become one of the most trusted voices in Georgia for analyzing and understanding the COVID-19 pandemic. As a result of these communication efforts, she was invited to serve as a member of the Georgia COVID-19 Data State Task Force, advising government agencies on how to package their complex data to meet the needs of the public. Our third panelist today is Robin Bussey. Robin is the community health strategist for ARCHI, which is the Atlanta Regional Collaborative for Health Improvement. Robin has been a part of the ARCHI team since 2012 and manages ARCHI's community-based portfolio. She has experience in community health through engaging communities to assess the health and well-being of their neighborhoods, and working with residents and organizations to build coalitions that design, and drive the work of community health improvement. She leads several community health improvement initiatives throughout Fulton and DeKalb counties, and is a co-designer of Archie's body of work focused on the health and social equity. Robin believes that racism is an influencer of health and that structural racism is the primary barrier to health equity. Thus, she is committed to highlighting and addressing the persistent inequities that impact a substantial number of the residents in the Atlanta region, throughout the state of Georgia and the American South. Robin is also a senior research associate at the Georgia Health Policy Center and the Andrew Young School of Policy Studies at Georgia State University. A member of the Population and Global Health team, she has worked on a variety of projects, including those related to public health program evaluation and strategic planning, community health needs assessment, and community benefit implementation strategies. Prior to joining the Georgia Health Policy Center in 2012, Robin worked as a senior health planning consultant at Platt HMC and as a health planning analyst at the Georgia Department of Community Health. Robin received her bachelor's degree in biology from Florida A&M University and her master's degrees in business administration and health administration from Georgia State University. Welcome, panelists. Let us turn now to our first panelist, Dr. Cleo Andrus, to learn more about the COVID-19 event risk assessment planning tool and the event risk calculator.
Wonderful. Hi there. How are you doing? Good. I just wanted to thank you for having me today. So I'm an assistant professor at Georgia Tech, and I worked with Joshua White, who is a full professor at Georgia Tech in the biological sciences and in physics, in creating the COVID-19 event risk assessment planning tool. What it does is this map shows the level of risk of attending a certain event. So let's go ahead and zoom into Georgia here. And we may be able here to zoom right into Fulton County. So what it allows the user to do is it allows the user to pick an event size, let's say 20 people. And it does reset every time we do have that issue. And then click on a county or hover over a county, and it shows the probability that one or more people at this event will be infected with COVID-19. So this means that as of right now in Fulton County, if you were to have an event with 20 people, there was a 12% chance that someone there might be affected with COVID-19. Now, these rates may continue to drop due to the vaccines and once people have 2 of their shots already. So it will be, we are looking to refine this in the future based on that information. But what it does is it takes into account the case rate at each county, and we pull these case rates from the New York Times API, the New York Times COVID API, which gives the rates of COVID-19 cases and deaths per county. And we pull that information in daily. So we have updates every single day here. And then it takes into account the event size as well. So how many people will be at the event? And this could be any event, like a picnic, a classroom. We had some people ask us over the summer about weddings, you know, how big should my wedding size be, etc. And then it also allows you to select an ascertainment bias. And this is sort of like a little bit of a sampling bias, meaning that for every diagnosed case of COVID that we have, how many other undiagnosed cases are out there? We don't just have this map for the US, we also have it for the world. So you can also click here on global estimates, and it will give you, well, not the entire world. We were only able to get certain areas that had COVID data available at small regional levels, but we have different global estimates depending on these province levels or depending on these sub-regional levels. And we weren't able to get these for all different countries, but we were able to get them for some countries. And so the same thing goes here. You can click on an event size, and then you can hover over the different subregions across different countries, and you can find the probability that there will be 1 or more people with COVID at an event you attend. I want to say that this doesn't take into account something like mask wearing. So it doesn't give you a good idea of probability of transmission. It also doesn't take into account whether the event is indoors or outdoors, which we know tends to make a huge difference in safety and transmission. You can read more about this model in a paper that we published called real-time interactive website for US county level COVID-19 risk assessment. And here are the lists of collaborators on this project. And again, this was led by myself and Dr. Joshua White. And we had just an excellent team of graduate students and staff member at Georgia Tech helping us, and one undergraduate as well. I want to say that this has also been very well received in the media over the summer and around Thanksgiving. There was a very big push to know, like, should I travel for Thanksgiving? How many people can I have around the Thanksgiving table? It might feel like it was a very, very long time ago, but we had a lot of press coverage then, and we also had a lot of visitors. We were averaging about 500,000 visitors per week during that time, and our site has received over about 9 million unique visitors, and we're still getting about 1,000 hits daily. So please use this tool if you're thinking of hosting an event or planning an event or attending an event. I'll show you two more things. One is this COVID-19 model. So we use the same model on our own personal website here. And we wanted to allow people to input different zip codes and a specific number of attendees. So what this does is it'll pull either county level data or zip code level data, depending on the granularity we have, and the number of attendees. So you don't have to think your attendees are coming from all the same county. You can say, oh, maybe we have a mixture of people coming from multiple places. And again, this was very, very helpful during COVID-19. So here's just one example. Maybe you have 18 attendees from this zip code. That one's adjacent to Georgia Tech. We've got maybe 10 attendees from this zip code. That one is at Georgia Tech. And then we might have some other people from other zip codes elsewhere. And then we can calculate the risk based on the number of attendees and different counties, even though these might be in the same county here. So this tool here lets you either peruse the map and look over it and kind of get a whole vision, or you can actually put in up to 5 zip codes here and number of attendees and get the risk level. That, again, this is not the risk that you would get COVID by attending this. This is the risk that one or more people at that event might have COVID. The last thing I'll show you is a map that we have of excess deaths. So we were interested to not necessarily just in the death rates of different counties, but the excess death rates. And the excess deaths here are calculated. It describes it below here, but the excess deaths are calculated as the actual COVID-19 deaths divided by the expected deaths by today's date in a typical year. And by today's date, we mean since COVID has been going on for more than a year now, we're still accumulating these dates. So the values are calculated as the number of COVID-19 deaths over the average age-adjusted death rate for the 3 most recent available years, and that's from the CDC, and then the fraction of the year that's completed. And again, we are entering into overtime here, so that fraction is over 1 now. And this is interesting because it allows us to go in to different counties like we had the other map. And this is done using our Shiny, and the counties are generalized for sort of faster mapping here. And it lets us see the percentage of excess deaths that have occurred. So which communities have been experiencing way more deaths than they would normally be experiencing. So excess means extra. So in addition to the normal number of deaths that this county would see in a year, what is that kind of extra tax on the deaths? And in Fulton County, we've got it up to almost 13. And this was updated last month, but we're updating it again today due to this webinar here. Whereas Cobb County's got 15.33, Clayton County's got 13%. We have almost 12% in Henry County, about 14.43 in Barrow County. And then to the north, in some of the smaller communities, we do see that this number gets up a bit. And then we do see that we also might remember that Columbus, Georgia, and some parts of more southern Georgia and and southwestern Georgia here experienced a lot of COVID-19 cases they experienced, an outbreak. And so we do see that there's some higher death rates in the southwest here. All right, and we did find from this that outside of Georgia, in the entire area, we did find from this that the smaller towns and smaller counties receive a higher percent of excess deaths. So it was areas that may not be highlighted by having many deaths, like, oh, maybe 15 deaths, 35 deaths, et cetera, in that county. But to these small communities, it's very meaningful because they don't necessarily experience that many deaths in a year. And so this is a huge extra tax on those communities. I will stop there, and I'm going to go ahead and I will hand this over to Amber. And thanks very much.
Hello, and thank you. Okay, so hopefully you can see my slides now. But yes, welcome to the webinar, and thank you very much for the invitation to be here. I'm excited to learn so much from the other presenters today and have a really great conversation. A lot of my data actually tags on to what Cleo had to share when it comes to rural versus urban disparities. But yeah, I think this is a great chance to kind of show off some of the work that's been done during the COVID-19 pandemic. So, you know, some of the work that I've been doing during the COVID-19 pandemic was writing a newsletter that has, you know, gained a lot of popularity to inform Georgians about what their public data is actually showing them. As you can imagine, public health graphs are not the typical graphs that we learned in high school and college. There's some nuance when you add in incubation periods and delays in test-seeking behavior. And so there's sort of a context that needs to be explained around these graphs. And so the newsletter hopes to do that. And through that work, I've been nominated. I'm a finalist now for a national award. It's called the Data Hero Award. So it's a pretty nice thing. But the other thing that I've been doing is working with some of our state agencies to develop the Geospatial Information Office COVID Data 19 portal. And this uses, it leverages the geospatial interfaces that we have along with public health data to really give people a good idea of what's going on in their neighborhood as much as possible. And this was used, we've also developed some tools that are more internal to aid decision makers inside the state government. And of course, this one is the one that's public facing that you can all use. In addition, I've done some advising and consulting work with different leaders, and I've just joined a new working group to work on vaccine access and vaccine hesitancy with the Metro Atlanta Chamber. So I'm excited for that too. So, you know, here we are now. We've been at this pandemic thing for over a year now, and I think it's important to reflect on what are the lessons learned during that time and how in the world did we get here. For a variety of reasons, CDC, who would normally be the leader in something like this, wasn't able to lead the way that I think many of us wanted during the early stages of the COVID-19 pandemic. And so what you saw was there was this big crowdsourcing effort at gathering data, packaging data into meaningful visualizations. And so that's why you see things like the New York Times and the COVID tracking project, and people that we normally wouldn't necessarily, they wouldn't be the key resource for us suddenly were, and thank goodness for it. I think it's a beautiful thing to see that many people engaged and concerned about their communities and wanting to help make data-driven decisions, but it didn't have to be this way. And so I think one of the biggest struggles in all of this has been really pointing people to credible sources and making sure that people are getting information from, you know, reputable places. And to me, you know, I like the New York Times, and that reason why is because they scrape their data from every state public health department. So, you know, it doesn't get much better than that. It's really good data. And I think that this pandemic has really highlighted the importance of data-driven decision-making. And that isn't necessarily something that every American often thinks about, but this pandemic has really made us stop and think about what is the evidence for this decision and how should I make this decision. What some of the key things that I've been trying to teach my readers and listeners is, you know, what are the best quality data? And to me, the very best data are the ones that are local, recent, and adjusted for population. As Cleo discussed, there's a very big difference between having 50 cases in Fulton County versus having 50 cases in Lumpkin County. And the reason why is because that could be a big chunk of the town in some of our rural spaces, and that's really pretty important. I also remind people to pay attention to trends rather than single data points, because there is a lot of day-to-day fluctuation. And I kind of highlighted earlier that there's a lot of nuance that goes with public health data. And some of the lessons that we've learned during this time have to do with conveying complex scientific information to a public that is not necessarily all scientists. In fact, most of them aren't. And so I think one thing that scientists sometimes tend to forget is that not everybody is a scientist. And so you really have to orient your audience to what they're looking at. Don't take for granted that people will automatically know what your axes are labeling. Don't take for granted that your color coding will make sense to them. Do your best to keep your graphics and visualizations simple and clean. And if you can't, sort of the adage is, if you can't explain it simply, then you don't understand it. So just make sure that you're thinking about those things. And I think really there's a lot of far-reaching implications for doing this right. Because if we can teach people to understand data and use data to make decisions, that's going to have impacts not just for this pandemic, but for a far-reaching span of issues, including issues of health equity, vaccinations in general, climate change, all sorts of things that are really, really important issues, and preparing for the next pandemic. And hopefully that doesn't happen for a very long time, but we need to prepare for it nonetheless. So this slide gives you sort of a flavor for the sorts of data visualizations that I have found to be very helpful. And so what I have done is broken up the state of Georgia into 4 main categories. That's the Atlanta counties, and I define those as Fulton and DeKalb. The Atlanta suburb counties, and those are set by the Atlanta Regional Commission. I was following you guys from the very beginning. And then non-rural counties are those with more than 50,000 residents, and rural counties are those with less than 50,000 residents. And then the black line on these graphs is showing you the state average. And so on the left side, what you're looking at is the 7-day case rate per 100,000 for the state of Georgia from those different county types. And you can see where the 3 different surges have happened. Try not to pay too much attention to this blip that's happening right here. That is when the Department of Public Health gave us 26,000 antigen cases all at once. So there's just sort of an artifact in the data there. So try not to panic. But what I want to point out here is, if we look at, this is where we have been over time, but this is where we are sort of now at this point. The cumulative case rate, we can kind of see how intense the pandemic has been for different parts of the state. And, Atlanta did pretty well when you consider their population and how densely compact they are. They didn't see the case rates that we saw elsewhere. But when you look at things like death rate, then there's an even bigger disparity. What you'll notice when we look at the graph, the line graph that is that rural Georgia, which is labeled in yellow, has had a disproportionately worse experience when it comes to death rate through all 3 surges. And so that makes sense then when you look at the cumulative death rate, that they have a death rate that is more than twice as high as what has been experienced in the Atlanta area, as well as the suburbs that surround it. And so this is really sort of an issue that we're going to have to really contend with. Is it an issue of attitudes about the pandemic? Is it an issue of healthcare access and healthcare deserts, socioeconomic determinants of health? There's a lot of different things that could play into this. So that's really all the time I have for today, but I did want to point you to these resources. If I can be a resource to you to help you understand the pandemic, or convince you to get a vaccine, I'm all ears and willing to help. So that's it for me for today. I'll go ahead and turn it over to Robin, who I'm very excited to hear from.
Thank you so much, Amber. Thank you, Cleo. Thank you for the invitation to speak today, and thank you all for attending. I'm glad to virtually see you all. So I just kind of want to talk a little bit about access to information. So the information and the data that you get when you're, as Amber pointed out, when you're not the scientist, when you're a person trying to live your life every day, which most of us are. And really, we are, she said a year out, and we are really, a lot has happened. And I really kind of want to focus on where we are right now in terms of the vaccine. But before I continue, I do want to hold space for all of the lives that have been lost from COVID-19 and all of the lives that have been impacted. So I really want us to continue to hold that space and lift that up as we have these discussions. So when we're talking about the vaccine, there for me are really kind of 3 concurrent issues. There's vaccine hesitancy or vaccine confidence. It depends on which lens you're looking through. Equitable distribution, as well as access to information. And in my opinion, hesitancy is really kind of not the most pressing issue of the three. The other two are really the really biggest issues that we have to contend with and try to overcome. And then at the same time, really address increasing vaccine confidence and trying to reverse vaccine hesitancy. And I say that because the news has reported very recently, over time, the number of people who remain vaccine hesitant, who are just like absolutely not, has really held the center. It's been pretty consistent since the vaccine has been released. However, those who are in the kind of wait and see category, that's beginning to shrink a bit, because people are really starting to get the vaccine and they're trusting their friends, family, and neighbors, their experiences, and that's starting to kind of move them into encouraging their confidence. So in Georgia, it's been all over the news. Our vaccination rates are low. We are at the bottom or very near the bottom in vaccination rates. As of yesterday, 15.9% of the total population have received at least one dose of the vaccine, and less than 10% of the total population is fully vaccinated. And when we look at those rates by race and ethnicity, white people have been vaccinated at almost 2 times that of Black people, and almost 6 times that of Hispanic or Latinx people. And these disparities can't solely be attributed to vaccine hesitancy and trying to encourage vaccine confidence. It's really about access to information and equitable distribution. So I'll really kind of focus on those two things. It's really important when you're, when you're doing all these things or producing all these data sources, to remember that everyone does not, hard to believe, have access to the internet. They don't have great access to the internet or consistent access to the internet. A lot of what they rely on is really their friends, their families, their community networks. And that's where the trusted sources of information have to be. So that's really, when we're trying to get these messages out, that's where we need to start. That's where we need to go where people are. None of this is rocket science. It's really community engagement and outreach 101, but it bears repeating. You really have to go to where people are. You have to identify those trusted sources of information, those trusted institutions and people within communities, work with them, and really start to get them to understand the importance of the vaccine, of why we need the vaccine, of why we need to continue to take preventive measures and all the safety measures like wearing masks and still distancing. Really having that understanding and working with them to get that information out. I have to say, anecdotally, I have seen lots of different information. It's very hard to navigate in terms of, where do I go to get a vaccine? Where do I go to sign up? When am I eligible? All these things are really confusing to people like me who work in this space. So I can imagine they're even more confusing for people who really don't even have time to think about this in a normal day. So we really have to make sure the information that we are sharing is equitable, it's streamlined, it's very easy to access, and as many people as possible can reach it. So what we need to do is to, again, go where people are, go to those trusted institutions like churches, like shopping centers and things like that, to really get the information out. And it also, onus is on us as everyday people to really become that source of information. So when you're educated about something, start to become that source of information for your family and your community. If you are able to get your vaccine, go ahead and do it, and also try to help someone else sign up and get their vaccine. Over time, I've seen that, people have become very informal sources of information through group texts, through sharing texts, through getting that information out. So it's really important, whenever you can, share that information. And the flip side of that is equitable distribution. So when you're sending out this information, understand that these people are not the only ones getting this information. For example, last week, I happened to get a text from a friend of a friend that a church had some extra vaccines. It's right in my neighborhood. It took me less than 5 minutes to get there. When I got there, the line was long. It was extremely long. And there were lots of people who didn't even live in that neighborhood. So again, what happens to those people who don't have access to that text, who don't have people who letting them know that the vaccine is available and they need to get somewhere very quickly, or they can't get there? So these are all things that we really need to be able to consider when we're thinking about sharing information and making sure information is accessible. I'm thinking about and really looking at the Get Out to Vote effort. I think that's going to be a really great example of how we can really rally communities to get the information out about the vaccine and get us to a point where we're getting more and more people vaccinated. Because as we know, there is no way that we're going to get to the other side of this, whatever that is, unless we get people vaccinated, unless we get, to use the phrase, shots in arms. So that's going to be really important. And again, the basis of that is really going to be getting information out to people, being trusted sources of information for people, and really understanding and respecting people's attitudes. So this is, again, where the vaccine hesitancy and encouraging vaccine confidence comes in. There's going to be some people that you're going to have to work on. There's going to be some people that you have to wait and see with, but it's really going to be worth putting in that time and that effort, so that, again, we can all get to a place where we are looking at the sunshine. We're on the other side of this. So I'm not sure how much more time that I have. Oh, I did have one more thing. There are lots of websites that have plenty of great information that you can share. It's easily digestible information you can send, you can print, you can post and share with people. I believe they're going to be in the chat. So there are websites like ourvaccine.org. Morehouse School of Medicine has a national COVID-19 resiliency network. There's a great website that was started by Black doctors, scientists, and nurses called betweenusabout.us.org. That really breaks down information from the clinical trial, how we were able to get the vaccine so quickly, what emergency authorization means, when you should get it, etc. And then it's also Alive and in Color, another website that gives you resources about how to have conversations. So again, when you're going to places where people are, to churches, to shopping centers, etc., this really gives you the information that you need to be able to share information, trusted information, and become that trusted source of information for your family and your community. So again, I will stop there and turn it over to David for more discussion.
Thank you very much, Robin, and thank you, Cleo, and thank you, Amber, as well for your presentations. As Robin mentioned, we will now turn this over to the question and answer portion of our webinar. And I would like to start with a question for Amber. Based on your research, what do the coming months hold for Georgia with regard to COVID-19? And do you believe the state's ability to provide vaccinations is keeping pace with our infection rates?
Okay, so there's a lot to unpack in what seems like a simple question, I realize. But what I will say is that, you know, the future of this pandemic is really what we want it to be as Georgians, in the sense that, yes, we are in a race to get as many people vaccinated as we can. And I think really the goal is to do so by summer, because what we have seen historically is that it's when people tend to gather indoors that we see our surges. So the summer, we had a surge in Georgia, and we did around the holidays and in wintertime too. So to me, really, that is one of our unofficial deadlines, is let's get as many people vaccinated by then. But we still need to see what happens with this more transmissible variant that has arrived in Georgia, and it's at least more than half of the samples that have been screened so far now. So it is gaining traction in the state of Georgia, and we have yet to see its real impacts. So those are the two things of sort of like the crystal ball forecast of where we might be headed. But I'm hopeful that the winter surge was our last surge, but I would not be surprised if we have one more in us. The second question you asked was about whether the vaccine rollout in Georgia is keeping pace. I think that there's a lot of room for improvement. As Robin said, we are historically right there at the bottom, and it's not just Georgia. Alabama and Tennessee are right there too. This is an issue that is very Southern in nature. And I think this has to do with cuts to public health funding and budgets over the past decade, and we're really sort of paying the price for it now. I think that we have some real issues with distribution, as Robin pointed out too. Right now we have a real scarcity of vaccine doses in the Atlanta metro, and we've got an abundance outside of the Atlanta metro, and that's going to create a barrier to access for a lot of people. You know, their ability to travel, their ability to take time off from work. Those are all issues that I worry about as well.
Thank you very much, Amber. The next question is directed to all of our panelists, and Robin actually touched on quite a bit of this during her presentation as well. Indiana University recently published data that indicated almost 38% of Georgians were hesitant to receive the COVID-19 vaccine. And I'd like to know if we could maybe hear a little bit more about what you believe is at the root of this hesitancy. Again, Robin, you touched on access as well, and if you'd like to, dig into this a bit further, that'd be great. But I'd like to maybe hear a bit more about what you feel is at the root of the hesitancy, and if there are any communications or policies that we should be considering to alleviate these concerns.
Sure, and I do want to say again that I didn't mean to allude that hesitancy is not a thing. It's a huge thing, particularly in communities of color, and there are lots of reasons. I mean, you hear the reasons of Tuskegee. You hear about other sterilization and forced sterilization issues as well, and these are very real. But there's also the general mistrust of the medical system, general mistrust of the government. That it's beyond how did we get it so quickly. It's, looking at things that historically have really impacted and really left people of color in the lurch, quite frankly. The government has not always been very supportive of supporting Black and Brown and Indigenous lives. So that's really going to be the root of it. And I think too, for people who are hesitant, that's very real, those historical reasons. But it's also, who do I know that has
bother you?
Who has experienced this? How did it play out for them? Am I going to go out there with the vaccine? I need to know, because you're hearing all these conflicting things. You're hearing things about, the side effects, which we know are pretty minimal. For one example, and shortly after Hank Aaron received the vaccine, he passed away. Totally unrelated, but that created a ripple as to see, I don't know, I can't trust this. So it's really, again, being very clear about information and really understanding and respecting not only the historical issues and frankly current issues that plague communities, but really kind of taking all of that into account and just really trying to be as mindful and as nimble as possible in addressing those things.
I'll just tag on briefly because I thought that was great. I think we need more opportunities for people to ask their questions and to get meaningful answers. Right now, we've kind of got a medical culture where everybody is really busy and nobody has time beyond the 15 minutes that they're seeing you. But we have real questions, right? And I don't think that we should take for granted, we shouldn't take our expertise for granted that everybody is going to just go along with what we say. I think it's really important to give people the space to ask their questions and give them answers. More often than not, people just want to be educated. They don't want to, I saw a really interesting study just the other day that people want to be educated, not indoctrinated. And so we need to give them the opportunity to be empowered about their decision to vaccinate.
Thank you, Robin, and thank you, Amber. I have a question for Cleo. We have a unique opportunity. We've had a unique opportunity to evaluate risk at a very personal and individual level, though how we each approach risk can directly affect other people. In your estimation, how do you believe this experience will impact our assessment of risk in the future? And do you believe that it has permanently affected our collective understanding that risk is not born equally?
I do think that the risk is not born equally has been really outlined with the fact that our essential workers are experiencing a lot of risk, and they are doing it, just to stay alive and to earn a paycheck. And then there's the people who are experiencing risk because they kind of wanted to hang out with their friends, and they thought that it was important to go to that bachelorette party, and they thought that they wanted to do that. And it's a similar amount of risk, but it's being incurred in such different ways. And we all have this kind of sweet spot that we all feel like we're in, but we give ourselves a pass. We're like, you know what, I'm doing the right thing. I'm living my life a little bit, but I'm also being cautious. Everyone tends to think that about themselves. And there is an old George Carlin, the comedian, he had a phrase once that said, everyone who's driving faster than you is reckless, and everyone who's driving slower than you is a total moron. And we totally saw that with risk too. It's like how much risk was good enough for you was so variable. But there weren't a lot of people who were out there saying, oh, I'm being very risky for no reason. The ones who incurred a lot of risk are the ones that had to. And so when people also got COVID, it could be I don't know how it was received in this country, but I know that in other places it was received as a huge stigma. Like you didn't want people to know that you got COVID. And in some other countries, they would put a yard sign out in front of your house, like this house had COVID. And I think that was in China, but it may have been Korea too. I don't remember exactly which one. But to get COVID as somebody who's in the medical community, like, wow, you really put your life on the line there, and that's what happened to you. But to get it from behavior that could have been avoided, from going to restaurants and stuff too, that's a little bit different. So we don't necessarily have a good answer to that, but we have seen that the perception of risk is very, very wide. Everyone has a different perception of it. So there was no clear number.
Thank you, Cleo. I'd like to go back to the vaccine question and kind of expand on one issue related to that. With the Pfizer and Moderna vaccines rollout and the recent approval of the third vaccine, the Johnson & Johnson one-dose vaccine, people are feeling hopeful that they may be able to return to some degree of normalcy in their lives. What are your thoughts on whether a vaccination may become mandatory in the future for schools or businesses? And this question is for all panelists, if you have thoughts on this.
I can start off. So with an EUA, it's really hard to require or mandate compliance with a vaccination. I think that things may change once the vaccines reach full FDA approval. Of course, they're still gathering data as part of their EUA. I think it's going to be interesting, right? Are we going to get to a point where you have to prove your immunity as either, having been vaccinated or having had COVID, and can you document that in order to board an airplane, in order to enter into a movie theater? I'm not quite sure how that's going to go. I'm a little nervous about it, actually, because of the stigma issues that Cleo raised, and so I don't have a good answer, but I will say that we can't really do it yet. Even the military right now is not requiring its members to take the vaccine, and because it is only authorized under an EUA.
So I'll just add, I don't think I have a very good answer for that either, but I think it's really key to just encourage people. There are lots from what I hear, there companies are often offering incentives like time off. They're offering maybe like a small bonus or something like that, which I think is good. I mean, if you just want to get $100 and you just happen to get a vaccine, that's really good for everybody. And then you made an extra $100. So whatever your motivations are, at the end of the day, you get a vaccine. So I think as much as possible, we can just, at this point, as Amber said, until we get to a point where we reach full authorization, let's just try to work together and see what works for people, what makes sense. And just really, again, in the vein of equity and really considering where people are, there's lots of small things we can do as a community. You can give people free rides. Everybody loves a free Chick-fil-A sandwich. So, just little things, I think, to really encourage people to take the vaccine, I think are really important right now.
Great. Thank you all for weighing in on that. Another question, again, to all the panelists. Would you mind sharing why you decided to take on this research, or what brought you to this research, and maybe how you felt as you began that process, and to where you are today, potentially a year later?
Well, I'll kind of start here as well. So at Archie, I think maybe at the end of 2017, we became really intentional about health equity, about really communicating what it is, working with our partners to help them understand what it is, how we can get closer to achieving it, although equity is a process and an outcome. And it felt like when COVID happened, and it was, and I hate to use the pun, all these inequities were unmasked. It was like, this is the Super Bowl. This is what we have been telling you all along. Like, this is what we've been trying to get you to understand, because at that point, these inequities were undeniable. And really, it became an opportunity to really get people to understand that these things were not new. They've been exacerbated. We have a real opportunity to make a change, this change, so that when we get to, again, beyond COVID, whatever that means, that we don't go back to a place where we can perpetuate these inequities. So for me, it was a bit, it was inevitable, but it was also kind of like, this is it. This is the time to really take advantage and really get people to understand the message that we've been trying to get across.
Thank you, Robin. Does anyone else, would you like to talk a little bit about your journey to doing this work?
So I noticed that, you know, at the beginning of the pandemic and stuff, there was so much, our geographies, and I'm trained as a geographer, they changed quite a bit. You know, there was this hyper local, my grocery store, the toilet paper, my neighbors, can we go outside? Is their dog gonna get COVID and infect my dog? And then the wherever. So we have the hyper local, and then we have this ether where we're zooming and stuff with everybody else. And so the focus, the immediate like safety and stuff really had to do with that locality. And so putting things on a map was really important because it gave us personalized, tailored case rates. So we didn't have to use like the country's case rates or even the state's case rates. And I will say that Georgia, you know, when you're a map maker, it can be a total pain to map this state. You know, you got so many counties, you're labeling them, the labels don't fit into them, this and that. But when it comes to granularity and having fine-grained data, we're at an advantage. We are, Kentucky is, parts of Texas are, not all of Texas, in that we got fine-grained data that gave us a really nice look at what's right around us. And so that really motivated me to get into this project, was to refine things so that we can focus in our community in a data-driven way.
And I'll just finish then. So when the pandemic started, one of the real moments that I knew that was real was I used to work for Dr. Nancy Messonnier, who is the leader at CDC, who came out to the media and said, I've already had the conversation with my children that things are about to get very different. And I've called my children's school to ask what their plans are. And I'd worked with her before and knew her always to be a very cautious person. And so it was sort of like, if she's saying it's real, then it is real. And I went to the grocery store that very day. And I didn't clear them out of toilet paper, but I did, you know, buy some ground beef, and I was ready for sheltering in place if I needed to be. But what I will say is that after that, what we saw was increasingly the people that we would normally trust to be our information, our communicators during this time, they were increasingly silent. And I still am friends with a lot of folks at CDC, and more often than not, the message I was getting from them was, we can't say anything. And so knowing that and seeing my student body full of scared medical students, the people that were in my sort of orbit, I was sort of like, how do I get my people through to the other side of this? As many of us as we possibly can safely. And so, you know, I was using tools like what Cleo has developed to really communicate risk, and to, you know, sort of teach them about how infections are transmitted, what an R0 value is, what are the data trends showing us, and how can you best protect yourself based on the best guidance and information we have at the moment. So that was really, I never expected to be in this position. It was really a moment where there was a vacuum of leadership and communication, and I looked left and looked right and realized that I had a role to serve, in the sense that, you know, I had a unique skill set that was ready for that moment.
Thank you very much for sharing. I have a question from the audience that I'd like to ask the panelists. What do you think we may see in the future when it comes to maybe comparing the COVID vaccine to influenza vaccines, where we may have an annual or a yearly vaccine schedule where they, you know, take into account mutations? Is that something that you imagine we may see in the future?
I can go. I think that we are most likely going to see this virus. Of course, our vaccines are going to help to knock it down, but I'm not sure that we're in a position to eradicate it. I think that that ship has unfortunately sailed when we had so much disease burning through our communities unchecked. it's almost too big of a problem for us to eliminate altogether. So it's possible that we may be talking about a booster shot at some point in the future that does take into account some of the newer mutations. And what's really nice about these RNA vaccines that are available is it's very easy to make those changes. And the FDA has already indicated that the booster, if they do swap out one piece of RNA for another, will not have to go through the rigorous, or it will have to go through safety checks as usual, but it won't have to go through 70,000 trial participants, for example. So kind of like how the flu shot is every year, we update it every year based on the previous year's most prevalent strain types. Something like that could happen for the COVID vaccine as well. But really, I think we really need to just try to get as many vaccines into arms as we can, because the more we let the virus replicate in our communities, the more chances it has to mutate in the first place. So if we can limit that, then we see fewer mutations and there will be fewer needs for boosters.
Thank you, Amber. Robin, Cleo, do you have any thoughts on that? Okay. Didn't want to cut anyone off. I have a question, Robin, for you. And so this kind of dovetails with the vaccine discussion as well. Do you have any thoughts on how we may think about addressing political polarization when it comes to taking the vaccine? Is there anything that you could share with that? Maybe is it something that we should be dedicating more time to, like community-based outreach? Any thoughts on how we may approach that?
Yeah, I mean, the short answer is we absolutely should dedicate more time and resources to community outreach, and we should also think about non-traditional ways of doing that outreach. I mean, I'm in favor, if we have to, let's go door to door. I don't know how that would work, but I mean, I think that's just how important it is. And in terms of it being political, I won't wade too far into it because we could be here all day, but I think it's just really important for people to understand that although there was definitely disproportionate impact in some communities, there's probably not one person who has not been touched in some way by COVID. We could all get it. We could all get very sick from it. So it doesn't matter, who you voted for, how you vote, what sticker you have on your car. COVID doesn't care. You could, very easily get infected no matter what side of the aisle you're on. So as much as possible, just trying to make it and again, I don't want to sound so cliche, a human issue, an everybody issue versus, this person or that person or however you vote or whatever your political leanings are. I think we have to really just make it a people issue. I mean, how we do that, I'm not sure, because, who would have thought that masks would be so polarizing? I mean, it's literally a piece of cloth that probably costs you nothing. You can get cute ones. So, it's really, whoever thought that. But I think, as much as possible, and again, I hate to say I don't know how we do this, we have to continue to really drive it home that this could literally affect any and everybody, no matter what you look like, where you live, etc. And, we really have to be in it together if we're ever going to get past it to that normalcy that we all want to get to.
Very well stated. Thank you. Thank you. I have a question from the audience for Amber. And this is about how the messenger RNA is different from other vaccines. Is that something that you could maybe touch on?
Absolutely. So this is a brand new platform of vaccines. We've never done this before, but we did have some studies ongoing for this for the last 10 years or so. There was a part of the Department of Defense that was developing this as a potential tool at some point. And so when it came time for COVID, what was really nice about well, there's nothing nice about a pandemic, but it does inspire ingenuity when you have these moments of crisis. And so you saw people willing to take the risk of seeing whether something like this would work. And so they started doing those studies with the COVID specific information, and they found that it did work. And it didn't just work, it worked really well. And it was really safe. So that's been really great. These are different in the sense that, so RNA is a temporary copy of the instructions to make the spike protein. protein that you see on the outside of all the graphics for COVID-19. And so what happens is the RNA is packaged inside of like a ball of fat that looks a lot like the cell membranes of your cells. And so that's what's injected. And RNA is a very fragile molecule. It has a tendency to fall apart very rapidly. And so when this is injected, that fat globule sort of merges with your cell membrane and delivers the RNA into the sort of cellular components of your cells. And what happens then is your machinery, actually, your enzymes actually make protein from those instructions. But the mRNA is kind of like in the Mission Impossible stuff, the idea of a message that self-destructs in 30 seconds or so. You know, I'm oversimplifying, but it is going to fall apart really, really fast. But you're making these proteins, they're shown on the outside of your cells, and that's what trains your immune system. So, you know, I think this is a really neat tool. I think it has the potential to change the way we do a lot of vaccinations, actually. And it could mean that, you know, maybe we're closer to getting a vaccine for things that we've never had success with, things like HIV or other really, really pressing issues.
Thank you, Amber. Didn't mean to put you on the spot. I know that's a complex question. We have another question from the audience. This is to the group. Are you aware of any strategy to combat concern regarding trusting pharmaceutical companies and the FDA? And this was, I think, related potentially to following the role in the opioid crisis. So because this has been obviously a major issue in rural communities, are there any thoughts on how we should work to help folks build trust with the pharmaceutical companies? I'll leave it right there. I'm having a difficult time concisely wording the question.
You know, I think we've all seen that meme from Pfizer. Like, I don't think they actually made it, but somebody made it for them. If you can trust us with Viagra, you can trust us with a vaccine. And I don't mean to make fun. That's not what I'm trying to say at all. But what I'm saying is we take pharmaceutical agents, or we use toothpastes or other things that are regulated by the FDA every day. And a lot of the times we don't do it with a second thought at all. I think it's great that people are asking questions. I think that we should all be naturally curious and skeptical and want to be confident in the things that we're putting into our bodies. But it's a little interesting to, you know, I see this vaccine as a miracle of science, that we had in less than a year sequenced the genome and produced not just one, but 3 safe and effective vaccines. So, you know, to me, I see this as an incredible step forward for humanity. But that's not the way that everybody is going to see it. And so I'm sensitive to that, and I want to make sure that people are heard and that their concerns are validated. But, you know, on a certain level, we have data to show us that this was done according to what needed to be done. They didn't skip any safety or efficacy checks. Those things were all done. They were just streamlined for better efficiency. And I think that, you know, I wouldn't recommend something that I wouldn't do for my own family. And everybody that I know in my family has been vaccinated.
Thank you very much. Robin, would you like to weigh in on that as well,
Yeah.
or Cleo?
I think that's key. I think what Amber was illustrating is that she is that trusted source of information, right? So there, you know, the betweenusabout.us.org site is really good. There are videos from all of these Black scientists, doctors, and nurses who are answering these very same questions. I think one question was, you know, the pharmaceutical companies are just out to make money. Why should we trust them? And they were like, of course they're out to make money. That's what they do. However, this is why you should trust them. To Amber's point, all these safety measures were taken. The clinical trials were pretty broad and diverse. So, you know, they've already gone through all of this information. Any major side effects that were going to happen have probably happened in the trial, so you can at least trust that. So I think, again, just really going to a source that you trust. Sometimes that person has to look like you or have your same experiences, but really being able to hear that information from a place that you're comfortable with, I think that's going to be key. And it, you know, it's not so much I guess, the pharmaceutical company, because of course we use that stuff every day, but just hearing that, yes, it's okay, the vaccine is fine. So yeah.
Well, it looks like we may be coming up on time now. Thank you all for participating. It's been a great honor to be able to kind of share the virtual stage with experts in your respective fields. And I thank you again for taking the time out of your busy schedules to join us today and to share your knowledge and expertise with the audience. I believe this is going to conclude the Atlanta Regional Commission's webinar on the importance of COVID-19 data. And I would like to thank, again, our panelists and our audience for joining us today. And I wish you a healthy and prosperous 2021. And I will pass it back to Olivia if she has any final comments.
Yes, thank you so much to our wonderful panelists and our moderator. We really appreciate you taking the time to join us today. As a reminder, our next webinar, Exploring How Vaccines Are Impacting the Economy, will be on Tuesday, March 30th at 2:30 p.m. So that's kind of a good continuation of this conversation that we've been having here. You can register for that on our webinar page. The link will be posted in the chat for that. And a recording of this webinar, as a reminder, will be available on our website by the end of the week. That'll be the same link where you can also register for the next webinar. So on behalf of the Atlanta Regional Commission and our presenters, thank you so much for joining us today, and have a wonderful rest of your day.
Thank you.
Thank you very much.
Thank you.